Good evening, ladies and gentlemen. We are back from Royal Pearl Hospital. So good evening, ladies and gentlemen. Today we are back from Royal Pearl Group of Hospitals, Trichy, Hyderabad. And today we're going to impart something very different, very nice, and very new in the field of otolaryngology. As you know, Royal Pearl Hospital has been striving very hard to propagate knowledge. And I want to catch the best people from each field in this country and try to, act as a bridge between the postgraduates, consultants, and the doyens in the particular field. So today we are going to have with us a very, very interesting personality. In fact, I know this great person from his early days, very, very sincere, humble, affable, and he respects his teachers. And both our teachers are the same, Dr. Ganadhan sir. And incidentally, I met him in Kerala, Trivandrum, and I was very impressed with his talk. And immediately I approached him, and he's Dr. Thiru. And Dr. Thiru, to tell about him, Dr. S. Thiru is a consultant pediatric ENT and airway surgeon in Kanchi Kamakoti Child Trust Hospital, Chennai. So a brief biodata about him. Of course, he needs no introduction. Now he is a very big person in the field of airway, pediatric airway. He is trained in pediatric airway surgeries, University Hospital in Switzerland, and presented at Quad conference held in Cincinnati Children's Hospital on October 22. And he has presented papers in various international forums in pediatric airway in Italy. He's got the second best paper award for prevalence of snoring in children and in an international ENT conference in Singapore. He's got a gold medal for best surgical video presentation, the State ENT conference in Kuttalam in September. And he has authored Bifid epiglottis with midline laryngeal hamartoma, a rare presentation of Pallister Hall syndrome in International Journal of Contemporary Pediatrics. He has co-authored a publication on prevalence of snoring in Chennai, India, among children, and authored a publication, Pediatric Inflammatory Myofibroblastic Tumors. But I know him on a personal basis. He's a very nice gentleman, very well read, very knowledgeable, and you can see that from his talk. And I have been very impressed. And this topic is a very new topic. Many people do not know much about it. What to do when a child presents with stridor and things like that. So today we are going to have a brilliant talk so this is divided into two parts. Today we'll have the first part for 2 hours, and then we'll have the next part on Sunday for 3 hours, Sunday evening. And so that will be a continuation of this lecture. Over to you, Professor Thiru sir, and that is all yours.
Thank you so much for your kind introduction. I owe a lot to you, and I'm a big fan of you. So here I'm going to talk on a very niche specialty in ENT. Though it is a niche specialty, now today's topic is going to be anatomy of larynx and trachea. So this is nothing special for pediatrics. So anatomy, what we need to know. So it's a general anatomy, and mostly why we should know the anatomy before going into the evaluation of the laryngeal and laryngotracheal pathologies and for the surgical management. So now I will share my Able to see my screen?
Yes, sir. Yes, sir.
Okay, so here we go.
Hello.
Yeah.
We are not able to get audio. Is it okay?
Audio is there. You're not able to get at all, or very low?
We are not hearing you at all.
1 second.
Shiva, can you hear? Shiva?
No sound, sir.
No sound, no sound. Yeah,
Really?
no sound.
Try now. Now.
No sound. No, not this. I don't know. White to white. No, I want this type C. Sir, sound varla. Sound is not coming.
Nothing is coming, or how is it?
We
Or
can
very-
see you giving a lecture, but I'm not able to hear you.
Okay, I'll try.
Shiva?
Is there someone to help us?
Yes, sir.
Because
Sound
I'm
is
able to
super
hear
good.
everything.
Hello, sir. We are not
Yeah.
able to hear what you have been showing as a recording.
Okay.
Only I'm able to hear your voice.
Okay.
Dr.
Now
Leena,
I'm
you are
able to hear what
voice,
you're
huh?
talking.
No, can you hear the voice?
yeah, I'm able to hear.
No, sir. No. What he is trying to teach, we are not able to hear.
I'm able to hear everything.
Yeah.
The sound is full. Why it is not coming in Zoom, I don't know. I don't know how to sort this out.
Shiva, can you help?
Yeah, yes, sir. I will try.
Shiva?
சார் இந்த ட்ரை பண்ணிட்டு இருக்கேன் சார். என்னன்னு தெரியல சார் எனக்கு.
ஆடியோ இல்லப்பா.
Here the audio is full, 100%.
Sir, can you
Share it again.
Share it
Go
again.
back. Share it again, please. Yeah. Shiva,
sir,
Shiva, can you control his computer from Trichy? Quick time player.
sir, yes, sir, I will try.
Ask him to send the password.
Yes, sir.
Ask him to send the password. You control.
No,
From here.
No password. No password. It's free. So I'm sharing it again. Hello.
Sir, 1 minute, sir.
Yeah. Can I play the video?
Yeah, yes, sir. Sir, actually, inside the Zoom, can you go into the audio settings, sir?
Okay. This is yeah. Select the microphone. Select speaker.
Yeah, yes, sir. Where you can go into audio settings.
Okay. Okay.
There.
You're able to see my screen?
Yeah, yes, sir. Screen is visible, sir.
Yeah.
Sir, in the test speaker,
Okay.
click
This is same as system.
yes, sir. It should be actually.
Okay.
Are you using any headphones or any mic system,
No,
sir?
no, nothing. Can I try playing it again?
Yeah, yes, sir. Sir, in microphone, can you click built-in microphone? Can you click that arrow where that it has test mic, sir?
Yeah. Okay.
Nearby, click that arrow. Yeah.
So
Please.
that is also again same as system.
No, sir. Click that microphone eraser. Yeah. Can you try sharing again, sir? Now.
Okay.
No, sir. It's not audible.
Not audible?
Varla. It's not audible.
Okay.
Sir, it's actually
No.
low. The sound is actually low, sir.
No, this is full sound. Now?
Here, I'm not getting sound at all. Zero sound.
No sound at all?
Yes, sir.
Okay. Doesn't matter. We will share this pre-recorded video later on. So I'll go back to my presentation. I'll start presenting. Is that okay?
Okay, sir. Okay.
Yeah. Okay.
Yeah, we can see your screen, sir.
Yeah,
Airway
sure.
evaluation in children.
Yeah,
Yeah,
yeah.
yeah, please.
Right. So, Airway evaluation is the next topic. It's again, basically the anatomy, but anyway, but we are not going to talk anything about the external anatomy now. You can see those things in detail. We will post it later in the YouTube. You can go and watch. So now I'm going to do the internal anatomy part. So how we will do the airway evaluation in children. One second. Okay, so why we should know about the pediatric airway? Because almost like 1 in every 1,000 patients coming to our hospital had airway symptoms in our recent study of for the past 10 years or so. So we should know, as an ENT surgeon, I should know how the symptoms will be and how I can evaluate those patients. So history, I'm audible, right? Able to hear well? Hello?
Yes, sir.
Yeah, sure. Okay. So history wise, I generally don't give too much of importance for the history, except 2 questions, whether the problems are there since birth or the problems developed little later. So these are all the 2 questions I want to know, because whether the problem is congenital, in that case, the management will be different. If it is acquired, then the problem will be different, and the management and evaluation, everything is going to be different. For this purpose, I ask only 2 questions, and then I move on to do the evaluation. The evaluation is basically one thing is like endoscopy. So endoscopy, endoscopy, endoscopy. This is the 3 things what we need to do for pediatric evaluation. We don't rely on any other investigations except endoscopy, because endoscopy is the gold standard. You will understand why I am telling this, why I am stressing this at the end of my 2 days of lectures. So we start like this with awake endoscopy, flexible endoscope. We can use flexible fiber optic bronchoscope or flexible nasopharyngeal laryngoscope, whatever you have. Even nasopharyngeal laryngoscope will be quite enough for the full complete airway evaluation in children. So you start like this. When the child is awake, maybe we'll give a little bit of sevoflurane for the child to sleep. And then we slowly go between the septum and the inferior turbinate. You can see the posterior part, the choana. What you're seeing is a little bit of adenoids, and then the soft palate. What you're seeing there is epiglottis. So you can see the movement of the supraglottic part. And then you can see the aryepiglottic fold, retinoids, both sides piriform fossa, and false vocal cord, and then vocal cord. Once you are there, you are not able to see the complete inlet of the larynx. What you can do is you can use your left hand to lift the chin a little bit, so that you will be able to see the inlet very well. And if you want to pass the scope through that, it is easier for you to do that. So I'm showing the inside part of the endoscopy in a little bigger child so that you can clearly understand. So you can go just over the inferior border of the middle turbinate. You can see the middle meatus, by the way, and you can go along the inferior turbinate and the septum, go to the choana, see the posterior part. There is adenoidal enlargement, and then see the soft palate collapse, and then go down, see is there any pharyngeal collapse. Now we can see the epiglottis a little bit, but it is not completely opened up. Here you just lift the chin, your left hand, like I showed in the earlier video. Then you will be able to see the inlet of the larynx. So now you can see the vocal cord clearly and see the movement of the vocal cord. This is very important. So that's why we are doing a awake endoscopy first. And you can see the movement. Once you are sure the movement and the morphology is fine, and then you can slowly go down. You can see the subglottis and then go down in the trachea, see the tracheal wall. Is there any tracheomalacia? And then go to the right bronchus, look for any bronchomalacia, and see all the openings there on the right side. And then I'm coming down to the left side, seeing the left bronchus and all the bronchial openings. So now you have seen the functional anatomy well. So now you can deepen the child, can give little more anesthesia. Child can be without any stimulus so that the lumen will be wide open. You can now see the structural abnormalities. You can see the carina slowly come up. In some situation, you would want to count the tracheal rings also in case of laryngotracheal reconstruction surgeries later on, so that how many rings you can sacrifice, how you can do the reconstruction. You will get all the information what you want in this scope itself, in the flexible scope itself. And you can come up, see the subglottis, which is the narrowest part, and there is a complete ring. What you're seeing is the subglottis with the prominent cricoid cartilage, and then come up a little bit. Now the vocal cords are still, so you can see the morphology clearly. And now we can see the posterior glottis and mucosa of the posterior glottis, and then come up, see the anterior glottis, anterior commissure, and then you can come up a little bit, see the false vocal cord. Now you can reverse the child again and see the movement one more time. So the whole laryngeal inlet is closing now. And there is not much of a problem. This is a normal child. I want you people to understand the anatomy very well. That's why I took this video. Now you can see the petiole of the epiglottis and come out a little more and see the aryepiglottic fold, whether the supraglottic approximation is fine. Is there any abnormality? Is there any incoordination in the movement? Is there any problem in the cricoarytenoid joint? Every single detail you can see, and you can see you can even see the blood vessels running across, and any mucosal abnormality also you can see. You need to see the healthy mucosa, so that will be very handy in your reconstructive part. So now you can see the movement of the arytenoids and the epiglottic fold, anteroposterior diameter you can see, and lateral part. And when it closes, you can also see the piriform fossa and posterior pharyngeal wall. When you come up a little bit, you can also see the pharyngeal movements one more time. So once you have done this, if you want to see little more, you want to know a little more information about the larynx, you can use the rigid telescope, what we are using for our sinus surgeries. Use the Macintosh laryngoscope and take the rod lens in your right hand, and you keep the blade in the vallicula and pass your rigid telescope. You go inside. You can confirm all the findings, whatever you have seen earlier. So now we are going to see a case-wise endoscopies. You're able to hear the sound now? Anyone able to hear the sound?
No.
Okay, that's okay, no problem. So this child is one 1 month old baby with biphasic stridor. You can see the stridor part, and then aditoscopy. There was a history of intubation. Now we can see both the vocal cords, which is mobile nicely, and then you can see the subaortic stenosis. This is acquired stenosis, thin subaortic stenosis. So that means this will be amenable to endoscopic management. Generally, what we do is we make a Mercedes-Benz cut, that is 12 o'clock position and 4 o'clock position and 7 o'clock position. We make cut with sickle knife, and then we dilate with the balloons or bougies. Once that is done, you can see the same patient. You can appreciate there is no indrawing, there is no suprasternal retractions, there is no stridor. This is just the next day of surgery. So when the child is coming to you, what are all the things you should observe before going for endoscopy? One is the stridor. Stridor will be obvious. There will be very loud noise. And other part is voice and swallow. Generally, we give too much of importance for the stridor. We don't give importance for these two. So these are all very important to give importance for the voice and as well as swallowing. We'll see why in the following slides. So this child is 1 year, 8 months old baby. The child was aphonic since birth and exertional dyspnea. Nobody gave importance to voice, but when the child came, there was a stridor. Check this boy. He had a normal voice. Yeah. Hello. And this child is having stridor. At the same time, there is a Ryle's tube. That means there is feeding difficulty with stridor. So when there is stridor, if there is obstruction at this
Sir,
level,
Dr. Thirunagar, sir,
yeah.
somebody has posted, please click the sound button on the left of your screen for sharing. Do you have that button?
Sound button where? In the mute.
Shiva, click on share sound on the bottom left left of your screen. Pravilika Parashar.
Yeah. Let me just look at that.
Bottom left of your screen.
Sorry?
It's at the bottom left of your screen, Thiru.
Okay.
A share button, share sound button will be there. Bottom left now.
Screen sharing. Live stop share. So this is the only thing you have. You're able to see that. You guys are seeing it?
Boss, we can see, but we are not able to hear the
That's okay.
children. It's okay, no?
That's okay. That's okay. No problem. That's not much. You have to just appreciate the strider. That's enough. So you don't have to worry about that. So, one second. So here, so strider, when the child is coming to you with strider, then what you need to do is you will have to look for the sound, how the sound is. In case having inspiratory sound, then that means the obstruction is at this level. In case if we have expiratory strider, then the obstruction is at this level. If we have biphasic strider, then the obstruction is at this level. So
Unmute, Thiru. Dr. Thiru.
Yeah. Now you're able to hear?
Yes.
Yeah. Okay. So okay. I don't know, it got stuck once again.
Sir, can you share it again, sir?
Yeah, okay.
Please end the sharing and you can do the sharing again, sir. Sir, while screen sharing, there will be a checkbox, it seems, sir.
One second.
Yeah, sir.
Yeah.
Sir, just click that PowerPoint and there will be a screen called share screen sound in your left bottom corner.
Don't bother. We don't have to waste too much of time for that. Don't worry. The sound is not all that needed now because I'm going to present only the PowerPoint. So don't worry, leave it. So this is how the strider would be. So then we have to do.
Screen is not visible, sir.
Not visible?
Yeah, yes, sir. Yeah, it's visible now, sir.
Okay. Okay.
Yes, sir.
Yeah. So here we go. So maybe we need to know more about this particular slide. That's why it's coming back again and again. So it is a good teaching for the PGs. So inspiratory, expiratory, and biphasic stridor. So this is what you have to give importance. And another thing is there any problem with the voice or is there any problem with swallowing? So then scoping. So scoping means what exactly you will do as an airway surgeon. As an airway surgeon, scoping means you need to do transnasal fiber-optic laryngoscopy, that is called TNFL, and then fiber-optic bronchoscopy, that is called FOB, and direct laryngotracheoscopy, that is with the rod lens endoscope, like what we did, and then telescopic bronchoscopy. So sometimes when we need to just to do scopy for the lower part of the trachea, or when we need to intubate the difficult intubation, we can railroad the endotracheal tube through the telescopic bronchoscopy, and then you can pass down and you can check the lower part and then railroad the endotracheal tube, you can intubate. And when you want to do a foreign body removal, or when you want to use the telescope for the ventilating bronchoscopy, you can use through that. Sometimes you can use the ventilating bronchoscopy through the suspension microlaryngoscopy. So suspension microlaryngoscopy in GA, we have to suspend the larynx and keep it open for any airway procedure. For example, if you are doing a anesthesia, which is apneic anesthesia, then you will have to keep the larynx suspended all the time. So that means successive apnea, that apneic period, you will be doing surgery. In case if there is some problem, oxygen saturation is going down, then you take the endotracheal tube, pass the endotracheal tube through the suspension microlaryngoscope, and then ventilate nicely, remove the endotracheal tube, and do the procedure. So this is what we do for any airway lesions which will not be obscured by the endotracheal tube. And then ventilating bronchoscopy. We might have seen ventilating bronchoscopy for foreign body removal. Foreign body removal, we can use ventilating bronchoscopy with the spontaneous ventilation or jet ventilation, whatever way you want, you can use it. Sometimes when there is a difficult intubation, when you're not able to pass any scope, you can use the ventilating bronchoscopy to just negotiate the airway and go down. You can use the ventilating bronchoscopy also. So as an airway surgeon, you should know all the scopies and you should switch over from one scopy to another scopy whenever is needed, because sometimes when the patient is referred to you, people will think you are doing only the laryngoscopy. Sometimes they'll ask for flexible laryngoscopy. Sometimes they'll ask for fiber-optic bronchoscopy. Then they'll send the patient for fiber-optic bronchoscopy to some other bronchoscopist, generally the pulmonologist. Actually, as an airway surgeon, if you do everything, then that is what is needed, the basic criteria for an airway surgeon to do all the surgeries, both endoscopic and open surgeries and post-operative follow-up and everything. So we will see one by one in different scenarios how we can do endoscopy. So in our hospital, we did this review of case records from 2014 to 2022. We have done 1,347 airway endoscopies for 1,038 children. So this is the statistical analysis for those who are interested in statistics. So this is the statistics I want you people to look into. So in our case series, in 1,038 cases, there are some 165 laryngomalacias. That means 15.9% of the cases are laryngomalacia. And interestingly, all the other statistics are almost incomparable with any published statistics of the literature. And one important thing here, what you want to look into is the intubation injuries. The intubation injuries we generally neglect. When there is intubation injury, what will happen? Immediately, there will be multiple extubation failures, and there will be some amount of stridor. If there is stridor, if there is voice abnormality for more than 48 hours, then you need to do endoscopy to see what is happening there. Unless otherwise you do that, you will not pick up anything like mucosal lacerations inside, and that will go on to ischemia and then necrosis that will form a scar, and finally there will be stenosis, and the stenosis will need some surgical maneuver later on. So at this point, if you are able to prevent that, then that will be fine. So you will have to do scopy and see is there any abnormality in the mucosal laceration, or is there any granulations. Then you can just treat at that level. If needed, you can do some balloon dilatations at that level and reintubate with one size smaller tube and apply local steroid ointment and send the patient back to the ICU with the tube and ventilate for 48 hours and extubate. Then you will be able to save at least 90% of the patients to go into laryngotracheal stenosis. So these are all the age distribution. Interestingly, we have done more number of scopies for less than 1 month old children. And male-female ratio may not be that much important. And most of them are either congenital airway anomaly or acquired airway anomaly. These acquired airway anomalies are maybe over congenital airway anomalies because of the predisposing factors, and 27% are normal anatomy. And laryngomalacia, like I said, there are 165, and 1 second. You can see how the laryngomalacia will present. You can see the suprasternal notching. And this is the scopy. You need to do awake laryngoscopy. You can see omega-shaped epiglottis, short hair epiglottic fold, inspiratory collapse of the supraglottis. And this is typical of type 2 laryngomalacia. So almost 20% of the patients have undergone supraglottoplasty for symptomatic laryngomalacia. This is the case, one of the cases. We're done supraglottoplasty, the same child, 3 days post-operative, we can see the quiet breathing. So congenital laryngeal web, there are some 21 patients of congenital laryngeal web. You can see the web. This is type 4 Cohen's classification. So anteriorly, this is completely closed. Interestingly, the child was not diagnosed, and there was some mild abnormality in breathing. This is the girl you saw earlier. And because of the webbing, there was no voice, and you can see there is only posteriorly small lumen, and I'm not able to pass the scope through that. Then I did tracheotomy, and then through the tracheotomy, I used the rigid telescope to go down to see the lower airway. You need to rule out, is there any concomitant airway anomaly? Airway looks okay. There is some amount of bulging. And then I'm coming up, did retrograde endoscopy. You can see the posterior part of the web here. You can see the lumen. And here you can see the subglottic stenosis. The grade type 3 and type 4 Cohen's glottic web almost always will have subglottic extension. Then you have to be careful in diagnosing it by scopy. Then your management strategy will be different. Here I did laryngotracheal reconstruction for the kid after web release. So now you can see the subglottis. with costal cartilage grafting. The graft is nicely healed. And now I'm able to pass the scope down the trachea till the carina. You can see both the bronchi. To the same child, the voice has become normal. It's not no stride. Tracheoesophageal fistula, the regular tracheoesophageal fistula won't come to us, but the tracheoesophageal fistula repaired in newborn can come to us later on with recurrent aspirations. That means the tracheoesophageal fistula is either not closed or recurred, and most of the time this will not be diagnosed. How we diagnose is through the NG tube, we inject methylene blue and do a scopy. With a rigid telescope, we can just go through the trachea and you will see the lip just above the carina where the tracheoesophageal fistula was there, and inject methylene blue through the NG tube and look for any leak. Now you are seeing something is coming out through the opening. So that means there is a persistent fistula that is causing recurrent aspirations. Unless otherwise you do this, the routine barium swallow will not pick up, and this is the one way you can pick recurrent tracheoesophageal fistulas, and then you can just go glue that area endoscopically, the child will be all right. In congenital laryngotracheal cleft, nowadays we are seeing more congenital laryngotracheal clefts. Recently, we have seen one congenital laryngotracheoesophageal cleft, and most of the time these are not diagnosed or left without any suspicion only, because these children won't have any major stridor or any voice abnormality. Unless otherwise you give importance to the swallowing issues or aspirations, you will not be able to pick this up. So what we do is, you can see there is something bulging into the glottis and subglottis. So now you will have to suspend the larynx and take a probe, just retract that redundant tissue in the midline, then you will be able to see there is a cleft. That means there is a communication between the trachea and the esophagus. Now we can see the apex of the cleft, that is below the cricoid cartilage up to the first tracheal ring. That means this is, according to Benjamin English classification, this is 3A. So you will have to either do an endoscopic repair or open repair. And you will have to see the lower part also. Is there any other abnormality like associated tracheoesophageal fistula? There will be some amount of tracheomalacia. And then airway foreign bodies. Airway foreign bodies are routine. Anybody will do it. But sometimes, without your suspicion, there may be something different which can just sit in the airway, maybe in the trachea itself. In that situation, there won't be any kind of clue that there is a foreign body aspiration in case if there is no history, like in this case. The child came to us with severe stridor, and there is something like this. So that is pink frothy secretions. That means there is pulmonary edema. So what we do is, we just do a flexible scopy in this situation to see what is there in the trachea. And for our surprise, there was something sitting in the trachea, lower part of the trachea, just above the carina. So that is blocking both the bronchi. And then I used the telescopic forceps to go down and catch that, and slowly I retrieved it out along with the ventilating bronchoscope, because the telescope was not coming through the ventilating bronchoscope. And then we saw there was a huge badam, roasted badam. And immediately the child was all right, the saturation picked up. So the intubation injuries, like I said earlier, almost like 6.7% of our cases are intubation-related injuries. Our center is state-of-the-art NICU and PICU hospital, tertiary care center. Here, even here, we see a lot of intubation-related injuries. That may be because of the oversized tube or cuff pressure or because of the piston movement. And in these patients, if you are intervening, then you are saving a lot of problems. In peripheral hospitals, everywhere now, the NICUs and PICUs are doing a lot of good work, saving a lot of children, even 700 grams, 800 grams babies are being saved, but unfortunately with morbidities. So we have to be very careful in evaluating these children. One of these child was referred from Andhra, came to us with stridor post intubation. And when I did scopy, I saw there was some necrosis. And what we do generally is put another endotracheal tube, one size smaller tube, and inject neosporin H ointment over it. So this will surround the tube and the healing will happen all around the endotracheal tube. So the healing will happen all around. So wherever there is healing, that should be ideal situation for us. In case if there is a healing happening in the lumen, if it is not stented, in case if you are doing a tracheostomy for this kind of children and leaving the upper part unstented, what will happen? There will be beautiful healing, but the lumen will be completely closed. So that means if you are doing a tracheostomy, then above there should be a stenting. Then only you can have a good healing all around. That would be a desirable healing. Otherwise, you try not to do tracheostomy and put the endotracheal tube, allow that area to be stented, and healing should happen all around. Generally, after 48 hours, when we extubate, this will look like this. There is a good healing, but at the same time, some amount of mucinous deposits and fibrinous deposits, but airway looks okay, not much problem. I thought we are okay with this, but the child came back after a week with stridor. Then I went in there, I saw there is some amount of subglottic stenosis because that raw area is causing some scarring and subglottic stenosis. Here, I'm using the airway balloon to go there just to dilate that. So we can keep the balloon there for 2 minutes, or if the saturation goes down less than 70, and then we remove the balloon. Now you can see there is the nice dilation of the subglottis. Then send the patient, but patient came back again after a week with stridor again. So this time I thought I should go for tracheostomy because I can't keep on doing this again and again. But when I saw the inside lumen, the healing is good, except that there is some amount of bulging in the posterior wall. Otherwise, everything looks okay. So I decided not to do trach and keep the child on NIV. And finally, the child was all right. So if you are not able to do anything at this level, that is in the post endotracheal tube injury, that is post extubation stridor, if you're not intervening at that level, then there is a chance you will encounter subglottic stenosis. And in subglottic stenosis, almost like 6.5% of the patients are having subglottic stenosis in our series. And there are more number of acquired stenosis than congenital subglottic stenosis. In case if there is subglottic stenosis that may be superimposed with the endotracheal tube intubation without the prior diagnosis, that may cause more number of acquired stenosis, that is acquired stenosis over subglottic stenosis. You can see the retractions. This is a 1.5-year-old child, undiagnosed congenital subglottic stenosis. You can see the subglottis here. Vocal cords are fine, moving well. This is prerequisite to see whether the vocal cords are mobile. Is it the functioning is all right? The mucosa is all right. The posterior subglottic mucosa is all right. Then you see, is there any stenosis? If there are stenosis, it is a thin stenosis like what we saw in our first slide due to acquired stenosis, or if it is congenital stenosis, then there may be thick cricoid cartilage. In that case, the management itself differs. So for this reason, you will have to give more importance to see the subglottic area, whether the stenosis is congenital or acquired. You saw the dilatation I did in the first slide for the acquired stenosis, that is thin stenosis. Here, in this situation, you are seeing a thick cricoid cartilage. That means you can't do any endoscopic management or dilatation. You will have to go for open surgery. Here, in this particular case, I took a costal cartilage and put anterior grafting, and then child became all right. In case of tracheal stenosis, most of the tracheal stenosis are acquired tracheal stenosis. In case if it is a congenital tracheal stenosis, then the trachea, whole trachea will be stenosed. That means the cartilage will be like a O-ring. So instead of a D-ring in a normal trachea, there will be posterior membranous trachea and anterior cartilaginous ring. But in congenital tracheal stenosis, there will be complete ring all around. That means, again, you cannot do any dilatation because there is a ring all around. There is no role for endoscopic management. You will have to do only slide tracheoplasty. We have done a few cases of slide tracheoplasty with the help of cardiothoracic surgeons and with the BiPAP machines. So here, what I'm going to show you is the acquired tracheal stenosis. Once a child, though there is not much of a problem in the vocal cord or subglottis, because of the tracheal stenosis, the volume of the air burst for the sound production is less. So the child is having very less voice. That is another clue what you can get for this kind of children. Then you do the scopy. You can see vocal cords are fine, subglottis is fine. There was a history of intubation. Incidentally, the lower end of the endotracheal tube caused this injury, and the stenosis is almost at the lower part of the trachea. There's a very tiny opening there in the trachea. And then we did the endoscopic release with laser and dilated that part. And then the next day, the child is all right, and the voice has also become all right. So the vocal cord palsy, incidentally, the vocal cord palsy, the more number of vocal cord palsies are bilateral vocal cord palsies in children, unlike in adults. That means the child will be having a normal voice, but there will be stridor. In case there is unilateral vocal cord palsy, then the voice will be abnormal, there won't be any stridor. So most of the immediate attention need to be given to bilateral vocal cord palsy because the child is coming to you with stridor. And some of the children are congenital bilateral vocal cord palsy. Those children will improve on its own. That is, spontaneous recovery will happen within 2 years. That means you will have to somehow manage without doing any destructive procedure in the larynx for at least 2 years. And then if nothing works, then you can plan some procedures for those patients. In case, if the child is little older, then you can avoid tracheostomy. Straight away, you can go to Kashima procedure or posterior costal cartilage grafting to widen the posterior glottis, or any other lateralization procedures you can do to avoid tracheostomy. If there is no other way, you can do tracheostomy and try to decannulate the child before going to school. Then only the child can develop voice, normal voice. You can easily diagnose bilateral vocal cord palsy by the biphasic stridor. You can see it's a very severe stridor. And what you need to do is do the scopy, and someone from outside should shout inspiration and expiration. Interestingly, during inspiration, the vocal cord will be moving. That means there is a paradoxical movement. There will be adduction during inspiration and there is no abduction. So you should not get misled by there is some amount of movement in the vocal cord. So you will have to be very careful and picking up these patients whether the vocal cord is moving during inspiration or expiration. So when you are doing endoscopies, you should not just stop with one diagnosis, because 1% of the patients had 2 concomitant aerodigestive conditions in our study for the past 10 years. So that means you will have to do thorough endoscopy. Every single details of the airway needs to be known before going for any surgical management. Not just the airway, but also the aerodigestive evaluation is important, because in case there is some problem in the esophagus or in the stomach, then that can also prevent your reconstructive surgeries healing process that will impede your final results. So you need to be careful in evaluating these patients with multiple endoscopies, pan endoscopies. You should get help from your gastroenterology colleagues to do the diagnosis of something like eosinophilic gastritis or some amount of gastroesophageal reflux, sliding hernias. Those things will be the associated problems. Sometimes there may be tracheoesophageal fistula. Sometimes tracheoesophageal fistula would have been corrected without seeing the airway abnormalities. I have seen patients coming with multiple surgeries, history of multiple surgeries with airway abnormalities at the age of 5 years, 6 years, 7 years. So you will have to be careful in evaluating both aerodigestive tracts before going for any definitive management. So to conclude, case-appropriate endoscopic evaluation of the laryngotracheobronchial tree is the gold standard investigation. You would have been convinced by now, because I've shown you the different situations, how the scopy helps you to make a diagnosis and how it helps you to do the follow-up and to see whether your surgery is successful or not. So here we have the Chennai Pediatric Airway Congress happening in September 8, 9, 10. So these are all the highlights: live airway endoscopic evaluation, live endoscopic airway surgeries, live balloon dilatations, live self-expanding stent placements, lectures, and panel discussions from the experts all over the world are going to come for the conference, please note the date, save the date for the conference, and please contact us. Thank you very much for your patient listening.
Excellent lecture, sir. Fantastic. Really, really impressed. And showed, say, various conditions, and it can be diagnosed with a bronchoscope. Question from postgraduates are that what size of the bronchoscope you would like to use? Hello?
Yeah, I'm here. See, bronchoscope, there are different sizes of bronchoscopes we have. Nowadays, generally what we use is 3 to 3.5 size flexible scopes. So that means Pentax has got 3.5 flexible nasopharyngolaryngoscope, and Olympus has got bronchoscope of 3.8 size and 2.9 size. So the general bronchoscope which is being used is 3.8 size, so that you will have the suction channel. You can do the suctioning, and you can also do some procedures, whatever you want to do with that scope. And for smaller babies, you can use 2.9 scopes with suction channel also, but that may not be that effective. You will have to struggle a bit through the suctioning. Just to see what is there inside, you can use that. And if you need a suction channel, the 3.8 is ideal. But with 3.5 scopes, you can do all the scopies. For example, if you have only the 3.5 Pentax nasopharyngolaryngoscope, you can use it as a bronchoscope to see all the throughout the airway, both the bronchus, upper part, nasopharynx, everything you can see with that. If you want, you can use the rigid telescope and the suction tip, metal long suction tip separately for that purpose. Now, the AMBU has come up with the disposable scopes. So that means you can purchase a console, and there are disposable scopes of 3 size nasopharyngoscope and 3.8 size bronchoscope. So you can use both. And if you want to use for the adult also, you can have 5+ bronchoscopes which can be attached to the same console. And for the long telescopic examination and for the foreign body removal with ventilating bronchoscope, you can have 2.9 size Storrs long telescope. So that can be used.
Yeah. So are we going to have another lecture today?
I mean, if you want, or question and answer also we can do. Maybe we can have a better, we will be prepared for all the sound and everything next time. We will have an extended lecture if you want on Sunday. And now we can have a more discussion. If somebody wants to ask some more questions, I am ready to answer.
Yeah, the laryngomalacia, which is the commonest condition we see in our practice.
Yeah.
So suppose a baby comes on the day of birth with, stridor. Do you diagnose laryngomalacia? This is one question which many people keep asking me.
See, generally,
when does laryngomalacia start, and when does it, go on its own?
Yeah, generally laryngomalacia starts after a week. So if the child is having stridor on day 1, then you should suspect something else. You will have to look for the voice first. Is there any abnormality with voice and stridor on day 1? Then there is a possibility of laryngeal bleb or something else in the subglottis, subglottic stenosis, severe subglottic stenosis. In case if the child is all right, that's why I insisted on asking whether the child is having stridor since birth or developed a little later, because that question is very relevant. If the child is having stridor on day 1, then the possibility of congenital structural abnormality is high. Laryngomalacia is not a structural abnormality, it is functional abnormality. It will start slowly when the child starts thriving well and crying, feeding. Then because of the extended exertion, the child will slowly start to have stridor, and mainly the child will have inspiratory stridor, and that sound will be like something like something like that. This is the typical sound of laryngomalacia. You can easily see. And there is inspiratory stridor. In laryngomalacia, inspiratory stridor and voice will be normal. That is another clue. And it starts after a week. There will be some exceptions, but generally it starts after a week. If the child is having only laryngomalacia, there is no other comorbidities. If there is no problem like in the respiration, there is no problem in feeding, then we can just observe. But you don't brand the child having laryngomalacia without scoping. So in case if you're not able to scope, if you suspect laryngomalacia, if you think the child will thrive without much problem, then what you can do is you can write as probable laryngomalacia without any red flag signs. That is very, very important. Otherwise, what will happen without scopy, if you brand the child as laryngomalacia, and that notes will go everywhere, people will just see this and say this is only laryngomalacia, that will be all right without any problem. And most of the pediatricians will do that, and the patient will land up with problem later on. So you have to be very careful in branding a child laryngomalacia.
So if the baby has got laryngomalacia, so usually what is your protocol? How do you proceed?
Yeah, we will have to look for the red flag signs. So that means if the child is having any apneic episodes and cyanotic episodes and acute life-threatening events and need for intubation when there is laryngomalacia without any other airway anomaly. And if the child is having recurrent aspirations, if the child is failure to thrive, not gaining weight, and chest retractions are too much, then you will have to think about doing something for that patient. If these are not there, only the sound, and the child is thriving well, then you can you diagnose, you put it as laryngomalacia, and most of the time, what happens is people write the types of laryngomalacia: type 1 laryngomalacia, type 2, and type 3 laryngomalacia. The types are mainly for your surgical purpose. The types are not grading. Some people will think type 3 is severe, type 1 is less severe. It's not so. So the types are only for the surgical purpose, and the severity is only symptom based. And you will have to grade the child based on the symptom. If these are there, then subject the child for supraglottoplasty, and almost like 20% of the laryngomalacia patients go for supraglottoplasties. The 80% will be all right without any problem. Still, you will have to just follow that patients for any other problems, any other recurrent infections, or any other airway-related problems. You have to follow it.
Okay, you do your scopies under sedation only, or you do it without sedation?
No, I do all my scopies in OR. I don't do anything in my office. In OR, I start with awake endoscopy. If needed, I'll give little bit of sevoflurane so that the child won't agitate too much. And then I will see, like how I showed in my video, I see the functional abnormality first, like in pharyngeal collapse or supraglottic collapse, inspiratory collapse, vocal cord movement, and tracheomalacia, bronchomalacia. All these things I'll see, and then I'll deepen. My anesthetist will deepen the child, and then I'll do the complete assessment. If needed, if I am doing a probing or something for laryngotracheoesophageal cleft, then I'll suspend the larynx with complete general anesthesia and probe that posterior part to see if there any communication between the trachea and the esophagus.
So that means if you are having around 20-25 OPD, all patients are admitted. If you want to see the airway, all the babies should be admitted, and then you are going to give anesthesia for all the kids.
No. We don't admit the patient. We just do the scopy as OPD procedure in war. And in case if we have some problem post-operatively, we will admit the child. Before doing scopy, we will tell the parents it's going to be OPD procedure in case if there is some problem in the airway, because we don't know what is there inside. We don't have a diagnosis. After diagnosis, we may have to admit you if needed. Sometimes we may even have to admit you in ICU. So all these things we'll tell prior to the scopy and then take up for scopy. Most of the time, the child will go home on the same day without any problem.
No. My question is, you do the flexible scopy in the ward, but babies will not cooperate. No, some kind of sedation is required for the baby for to do the scopy, right?
Yeah, that's why I don't do at all. I don't do except in ward. I don't do scopy anywhere else.
Okay. Okay, I just want to ask you, suppose your babies generally have congenital abnormalities like heart disease and all this stuff. You have syndromic children and also, multiple abnormalities. So if they are not fit for general anesthesia, if they're not fit for drugs, then how do you proceed?
Yeah, so this is, the part of anesthesiologist issue. We always get a pre-anesthetic checkup before doing scopy. Even for scopy, I get pre-anesthetic checkup. And all the children would have undergone echocardiogram and cardiac evaluation before that. So in that situation, maybe if the child is having a major problem in the airway, then we will, restrict our scopy to just a flexible scopy to have a quick look. Because when there is cardiac problems, we may have to do any reconstructive procedures at that particular time. So we correct cardiac issues first, and then only we will go for this management. Only thing is we need to do diagnosis. So if we can make a quick diagnosis, we will do that in awake situation. But that situation is very rare. Most of the time, the anesthetists are very good. They can even manage with cardiac issues for anesthesia, and especially the sevoflurane and other drugs are cardiac safe. So we can just do scopy, and we can do the diagnosis and plan the further course of treatment later on.
Excellent, sir. Any of the delegates want to ask questions to Dr. Thiru? Please unmute yourself. Shiva, are you there?
Yes, sir. I will let them.
You can ask somebody. If they raise the hand, you can unmute them and make them ask the question if they want. Today we missed the lecture on anatomy of larynx, but it's okay.
Yeah. We will do it. We'll sort it out maybe on Sunday, and we'll do that also.
Sunday, what are the topics you're going to cover, sir?
So I thought of taking individual topics like, separate laryngomalacia, one presentation, and like laryngeal web, subglottic stenosis, tracheal stenosis, and laryngotracheal cleft or bilateral vocal cord palsy. All these topics we can talk separately. So we have just touched upon the endoscopy part.
Today was an overview of
just an overview. So all these things, whatever we have seen today, we can have elaborate discussion on Sunday.
Yeah. Any delegate wants to ask questions?
Hello. This is Satya.
Yeah, Satya.
Sir, good evening, sir. I think Sunday we'll have an elaborate lecture. We have a 3-hour, 4-hour session planned on Sunday.
Yeah.
So I think with the anatomy we can cover everything on Sunday. If needed, we can even schedule a meeting on Saturday on anatomy.
Anything is fine, but tomorrow is a little hectic day for me.
No, tomorrow.
You were telling me. Yes,
tomorrow, no need. I'm also a little. I want to listen to sir.
Yeah.
I'm the first.
So Sunday
student.
we can have like a extended lecture, sir.
Yeah. The Sunday is fine for me. Even yes, 2 sessions also fine. Morning session and evening session also we can.
No, Sunday morning. No, because I am operating on Sunday morning. Okay. That's why I planned it from 6:30. I told Satya I want to listen. So we'll have it from 6:30 to.
Sir, anyway, it will be there on YouTube also, sir. So a lot of people will watch it.
Yeah.
So
People
we'll
watch
plan
it,
that
but
next
I
time.
want to first hand watch it from Dr. Thiru.
Yes.
So nice of you to do that.
So
Because,
anybody
you
else
know,
wants to ask questions or we will call it a day? Dr. Satya? Anybody raising their hands? Dr.
Uh,
Anjama? Hmm?
no.
Okay, sir. So thank you very much, sir. It was a real, there is Mrutyunjay Bilagi.
Yeah, he's
Uh,
raised.
Yeah. You can ask your question, Dr. Bilagi.
Shiva, you can unmute.
Sir, I'm trying to, sir, but he's not unmuting himself.
so I'll ask him to unmute. So 1 second.
Hello.
Then
Hello,
this
Hi,
Dr.
sir.
Bilagi.
Namaste.
Sir, how are you?
ಚೆನ್ನಾಗಿದ್ದೇನೆ.
How are you? How are you?
ಚೆನ್ನಾಗಿದ್ದೇನೆ.
Yeah. Tell me, sir. I didn't expect you in this forum.
Yeah. My 90% of my work is Strider only.
Yeah, I know that. I didn't expect it no, today.
No, I'm watching. Janaki is my favorite chap. I like to.
Yeah, Janaki sir is a favorite of many
Yeah.
throughout the country.
I fortunately 90% of my work is Strider, United States, and
Yeah,
in a
I
month
know.
I keep seeing 25-30 cases every month.
Yeah, I know, sir.
Yeah, what you said is that once the patient with Strider reaches me,
Yeah.
he cannot die of anything, any other, at least in my center, he will not die. He'll be investigated, he'll be attended, and he goes home relieved of his obstruction.
Yes.
And the only tool I believe in, the only thing which helps is transnasal laryngoscopy, bronchoscopy, and I do even esophagoscopy at single go,
Okay.
in one go. And I don't sedate them. I don't do anything, just because many of my children are 1 hour child, 2 hour child, 1 day child, less than 1 month and all. Most of my children are. So that is right. But you know, see, once they have reached my place, they're strong enough, they'll sustain. And that the trouble these children, the scope I have is 3 mm scope. And it just doesn't add any burden on the survival of the affected child. They sustain. Nothing goes wrong. I've seen cases so far. I operated 400 cases with congenital conditions. 100 are laryngomalacias. The commonest procedure I do is supraglottoplasty. And now very few cases I've done epiglottomy, partial epiglottomy. That's all. And never in my case I had to resort to intubation or tracheostomy when they reach, when they are, whatever cases and so. Anything else? It was good. Your talk was wonderful.
Thank you, sir. Thank you.
Sorry. Next time I'll request Janaki to include my talk also.
Sure, sir. You're welcome.
Dr. Bilagi, for sure. I never knew that you're doing Strider work. I never knew also. So I'm sorry.
It's okay. It's okay.
In
I'm
fact,
not feeling bad
I met
about
Dr.
it.
Thiru in this pediatric, the
Definitely.
Trivandrum meet. There only I came to know that he's doing this work. Till then I didn't know because Airway is very
Yours is
far from
Kalpes.
us, no? So,
Yes, Kalpes.
so when I saw him, I was so impressed by his talk. I thought, let us,
Make it,
include this lecture. So, yeah. So the PGs, postgraduates will benefit a lot.
True. So I'll be there.
One, Dr. Thiru, one session, please, on Sunday when you're doing, show all the instruments. What are the instruments you have? If you make a small half-an-hour lecture on what are the instruments you have, for example, the bronchoscope or the forceps and all this stuff, no? It will be very useful for. And also you can make some X-rays, boss. for a foreign body, how to diagnose, like for example, emphysema or collapse, all this, no? This also will be very nice because it'll benefit the postgraduates a lot.
Sir, I have a doubt, sir. Would
Yeah.
you suggest any good books to read on pediatric?
Bible is
Pediatric-
Professor Philip Monier's pediatric airway.
Sir, can you repeat it, sir?
Monier.
Philip Monier.
Sir, your voice is breaking. Sorry, sir.
So this is
Pediatric
this
Airways.
book by Professor Philip Monier.
Okay, okay, got it, sir.
Yeah, pediatric airway. Sir.
Okay, sir.
Yeah.
Thank you, sir.
Okay, I think it is very nice that we had Dr. Thiru and Dr. Bilagi. Bilagi is known to me for a long time. I'm, I saw him in Trichy also. He came to Trichy for the Congress. And it's nice that he joined. So we have 2 airway surgeons now in the meeting. So it's very nice. Thank you very much, both of you, for having participated in this lecture. And it'll be very useful for all the consultants, postgraduates, everybody. We'll have an elaborate lecture by Dr. Thiru. I'm very impressed by his, talk. Thank you very much. And we will be back with all of you on Sunday. I'm waiting for Sunday to listen to his lecture.
Thank you so much, sir. Thank you. Thank you.
Thank you very much. Thank you very much, Dr. Thiru.